Mr. Chairman, dear colleagues, it's a privilege for me to give this talk today. So I would like to start saying that guidelines are written by common people and as such are subject to bias as any other type of research, because many times we look at guidelines as Bible, but I've been involved in guidelines myself. I've been in these task forces, and I must say that unfortunately they are biased by personal opinion. Most of the time people select the evidence they prefer, and again, they really must be looked with criticism by all of us. So I focus this talk on three main areas where large RCT became available in the last few months. One is the off-pump, on-pump debate, one is CBG versus PCI, and the other one is arterial grafts. For the off-pump, on-pump, as we know, so the Ruby trial published the 5-year comparison, and there is an excess in mortality and increased rate of major adverse cardiac event in the off-pump group. The main criticism of this study is that, as you know, the surgeons were required to have performed only 20 procedures. Conversion rate was very high, and resident was a primary surgeon in off-pump in 55% of the off-pump cases. And clearly, the lack of surgeon experience in the Ruby trial is a major limitation. The other large study with off-pump on-pump is the coronary trial, which enrolled 5,000 patients. This study was an expertise-based trial with surgeons required to have performed at least 100 procedures before being participating in the trial. Conversion rate was lower, and trainees were not allowed to participate. In the coronary trial, the two techniques showed comparable 5 years result, including myocardial deaths, myocardial infarction, stroke, and repeat revascularization. So we, as surgeons, we are focused mainly on surgical trial, but we really should keep following the cardiology trial because they are very interesting when results go against cardiology. They many times they concluded the study design was flawed. When they are in equipoise, they say that PCI is good. So this is the case, for example, of left main and CABG versus PCI. So we have two very large trials. One is the Nobel trial, which compared second generation drug-eluting stent versus PCI in left main, and the CBG was significantly better, not just in terms of repeat revascularization, because one of the arguments for PCI is that repeat revascularization is not a hard clinical endpoint, and in the Nobel, PCI was associated not only to an increased rate of repeat revasc, but also of non-procedural myocardial infarction. On the other hand, we have the EXCEL trial, which is an industry-funded trial, and in this case, CBG has been compared to everolimus stent, and the composite of death, stroke, and MI is comparable at 3 years, and the conclusion of this trial have been used by recent task force to say that PCI is a safe option in left main disease with less than 33 syntax score. However, looking with more attention at the EXCEL, first of all, the composite of death, stroke, and myocardial infarction is including troponin release peri-procedural. And as you know, CBG, especially if done on pump, is associated with increased release of troponin, which doesn't have any clinical relevance. Despite this observation, the study design still included the peri-procedural troponin release as a clinical outcome. On the other hand, if you look at the deaths, which still remain the most unbiased index because deaths in cardiovascular disease, all-cause deaths remain the most unbiased index, you can see that beyond 1 year, the two curves start diverging with an excess of deaths almost 50% in the PCI group. However, authors decided to not stress, not highlight this trend, which is alarming, should be alarming for the surgical community. So, based on all these new studies, we put together in a network meta-analysis all the evidence available for left main PCI versus CABG to try to better understand whether the introduction of new generation drug-eluting stent has improved PCI outcome in comparison with coronary surgery, because this is the main argument for cardiologists to push for PCI, is that second generation drug-eluting stent, they really do better, and therefore we should use PCI in this group of patients. It's very interesting because, as you can see, when CABG is compared to first generation and bar metal stent, there is no significant difference in the occurrence of death, MI, and stroke. And one explanation is because the first trials enrolled a lower risk population, so coronary lesion clearly were, left main lesion were probably easier to treat, and the two groups are comparable. However, when we pull together all the results we have from recent trial using second generation drug-eluting stents, PCI is associated with 30% relative risk increase in the composite of death, MI, and stroke. And this clearly is reflecting the current practice, where PCI is not only for simple left main lesion, but is used for more complex lesion. On the other hand, if you look at revascularization, while the introduction of first generation drug-eluting stent has reduced the risk of repeat revascularization when compared to bare metal stents, the introduction of second generation drug-eluting stent did not translate in any benefit in terms of repeat revascularization. So there is a misperception of the real benefit of second generation drug-eluting stent in the treatment of coronary disease. So what about the three-vessel disease? So we have 4 large trials, and the last trial is the best trial. And when we put together all these trials, and these are all multi-vessel disease, you can see that CABG provided better survival, better MI-free survival, better repeat revascularization-free survival, and the risk of stroke was not significantly increased. And this is the last topic, and again is the ART trial, which has been published with very controversial finding. The one IMA and 2 veins clearly use this data to say that the benefit from double IMAs is not that strong, at least to say it's not that strong. As you can see, so at 5 years, the two groups are comparable. So the first observation is that if you go to page 2 of the paper, there is an interaction analysis, and the p-value for patient with less than 70 is marginally non-significant, so it's 0.08, which I think is something that we should take into consideration when we decide to use veins in young patients. Moreover, as previously highlighted, there are many limitations in the study design with the ART trial. And the main limitation is that what we called beta is not actually beta, because vein graft was still used to supplement beta in almost 70% of patients. There is 13% of beta, what we call beta, that was actually zeta for the crossover. And on the other hand, what we call zeta was not zeta, because 20% of these patients received the radial artery. So unfortunately, the study design has some limitation that were not taken into consideration at the beginning. And I think this aspect may have neutralized the benefit from beta at 5 years. And, we may probably find the similar result at 10 years. So because of this limitation, we decided to look at what the patient actually received and which outcomes were compared to the conduit strategy. So the red line is patient who really had arterial revascularization, while the blue line are those who just had lima and 2 veins. And as you can see, this subgroup analysis that has been recently presented at STS meeting show that the composite of that MI and repeat revascularization, that MI and individual component are better in patients receiving arterial grafts. So I personally believe that the main issue with the 2 IMAs is the technical complexity, and that I think may result in a suboptimal outcome also in experienced hands. Just consider that the crossover in the ART trial was 15%, and these were all experienced surgeons in double IMAs. So there is 50% of patients treated by experienced surgeons that still present some issue during the operation, and this is just highlighting how complex is the beta procedure. On the other hand, we have another conduit, which is called the radial artery, which doesn't require any special adjustment. We can use the radial artery exactly the same way we use a vein graft. And it's very strange because most of the randomized trial on angiographic patency are on the radial artery. So we have 6 trials which has proved consistently that the radial artery provides better angiographic patency rate. However, all these trials were underpowered to detect a difference in clinical outcomes. And because we want to see a trend in clinical outcomes rather than angiographic patency, the rate of radial artery usage is still low. So in this paper that has been provisionally accepted in New England, we pulled together all these 6 trials, which were mainly trials based on angiographic patency, but they also reported clinical outcomes. And when we pulled them together, and so we got a much bigger sample size, we could demonstrate a significant trend towards a reduced incidence of MI with the radial artery and a reduced incidence of repeat revascularization with the radial artery. And overall, the composite of deaths, MI, and repeat revascularization was lower in the radial artery group. Even with radial artery, there is a strong interaction with age, with patients less than 75, who are those most likely to benefit from this procedure. Summarize the evidence in off-pump versus on-pump dilemma. The largest trial is the coronary trial with expert-based design that showed that off-pump is as safe as effective as on-pump. The Ruby trial showed an alarming increase in mortality in off-pump if performed by inexperienced surgeons and highlights the central role of surgical experience. Therefore, at the moment, I don't think there is any evidence to support that off-pump should be abandoned by experienced surgeons. In terms of CABG and PCI, the 2 largest trials on the left main disease using second-generation drug-eluting stent reached discordant conclusion. The Nobel was in favor of CABG, while Excel showed an equipoise between the 2 procedures. Excel PCI showed an increase in excess of deaths and longer follow-up is needed. Caution should be exercised for PCI on left main for complex lesion, especially bifurcation, and when CABG is at low risk. Available evidence support the superiority of CABG in multivessel disease. And finally, for arterial graft, the ART trial failed to show superior outcomes with beta. However, study limitation prevent definitive conclusion. Moreover, beta was only marginally non-significant in young, the benefit from beta was only marginally non-significant in young patients. Patient-level meta-analysis comparing radial artery and saphenous vein showed that radial artery not only provides better angiographic patency rate, but is associated with better clinical outcomes, in particular in younger patients. Therefore, I think an additional arterial conduit should be recommended in young patients, and the radial artery is a valid alternative to a second ETA. Thank you for your attention.